You're on GYN rounds, and you're presenting an uncomplicated total abdominal hysterectomy on postoperative day number 4. The attending asks why the patient is still in the hospital. You answer honestly. She was nauseated overnight. IV opioids went back on. She hasn't ambulated much. No one pushes back. We see this every day. It feels normal. It feels reasonable. But there's a problem. In an uncomplicated case, an extra hospital day means the protocol broke. A protocol shown not only to shorten length of stay, but to reduce infections, embolic events, and mortality. Enhanced recovery after surgery. ERAS. And here's the part we miss. ERAS doesn't fail all at once. This longer stay didn't start last night. It started at the pre-op visit, with a long chain of decisions that, together, pulled her off the pathway. ERAS fails through judgment calls, moments when the protocol is clear, but real life makes us hesitate. So in this video, I'm going to walk you through 3 settings where we quietly drift. Before surgery, during surgery, after surgery, and what to do when the protocol feels optional. Setting number 1, preoperative visit. This is where ERAS really begins, not in the OR, in the office when we counsel patients. Patient involvement isn't optional, it's a core intervention. When patients understand why ERAS exists, they participate differently. They get out of bed, they accept less opioids, they expect to go home as soon as possible. Counseling has to start early, at the first pre-op visit. Not just what will happen, but why it matters. This is also your window to identify real risk: smoking, alcohol, obesity, anemia, sleep apnea. These aren't background problems, they shape recovery. Smoking cessation works best at 4 to 8 weeks, but here's the real decision. Do you push at all when surgery is already scheduled? Short-term cessation still helps, and it doesn't cause harm like we thought in the past. Doing nothing does. Alcohol is the same. Asking vaguely gets you nowhere. 3 to 4 drinks a day can raise complications by 50%. 5 or more, and the risk multiplies. Bleeding, arrhythmias, ICU admission. Intensive cessation helps, but only if you identify risk and act on it. Use the pre-op visit intentionally. Set clear expectations. Name risks and minimize them. Educate. Because if the patient isn't engaged and risk isn't addressed here, everything downstream becomes harder. Setting number 2, day of surgery. Analgesia, fluids, devices. This is where habits hide. Opioids are effective. They're also expensive later. If IV opioids restart on post-op day 2, that's not a post-op failure, that's an intra-op signal. Either pain wasn't anticipated or mobility wasn't prioritized. Tap locks aren't magic. Sometimes they help, sometimes they don't. The mistake is not choosing wrong, it's choosing automatically. Same with fluids. Fixed recipes feel safe. They aren't. Too much fluid slows the gut. Too little hurts perfusion. And every drain, every Foley, every pack makes ambulation harder. Setting number 3. After surgery. This is where ERAS dies quietly. Ambulation was ordered, but not well defined or clearly emphasized to the patient. Ambulate as tolerated is not an order. Out of bed twice today is. Same for advanced diet as tolerated. Do not delay regular diet for nausea fear. IV fluids running on day 3 usually mean no one stopped them. Waiting for flatus is tradition, not evidence. You have time be clear and intentional with the patient. Make discharge criteria visible on day 1. If she can't meet them, ask why. Not tomorrow, today. ERAS is not a checklist to memorize. It's a framework for shared decisions. The steps are specific. The evidence is solid. But the real power of ERAS is how it forces conversation. Between surgeons and anesthesia, between nursing and residents, between you and your patient. When ERAS works, it's not because everyone followed orders, it's because the team followed a plan that was communicated to all parties involved. And when you use it that way, An extra day in the hospital in an uncomplicated case never feels normal again. Share this video and subscribe to Pathways OB/GYN for evidence-based updates, teaching hacks, and smarter AI strategies. The content of this video is for educational purposes only and is not intended as medical advice.